My name is Ladislau Steiner, interviewing Professor Urban Ponten. The date is April 18, 1994 in Stockholm. For me, it's like a Proustian à la recherche de temps retrouvé. I am back only for a few days in Stockholm, and I am glad to be able to interview a number of leaders in neuroscience from Scandinavia. Urban, you just retired from the professorship of neurosurgery from this prestigious institute from Uppsala, and you achieved quite a lot in your life. We would like you to show us how did you grow in this scientific world. How was your childhood? How were your first steps in the school, your mentors, etc.?
Okay, I was brought up in Stockholm and went to school there, and I also started had my medical education in Stockholm at the Karolinska Institute, which at that time had very old and charming buildings in the center of the town, including the Serafimer Hospital. Okay, there was nothing special with my studies, and I had why I became a doctor is I'm not quite sure about. I was ill for a few periods in childhood, might have played some role for my choice of study.
Anybody in the family was doctor?
No, none at all. Well, it's a lot of clergymen and priests in the family, and some of them also in the old days worked as doctors in the old days, 100 years ago or so. But that had really no influence on my choice, I guess.
But for Scandinavian people, it's quite usual to have his roots and to know of their roots deep in the past. Can you follow the roots of the family? How long do you know?
The family goes back to the beginning of 1700. The name comes there. There were 3 boys who went to the university in Lund to become priests, and they took the name Ponten. Then they came from a farm, which the bridge farm. So that's a direct translation. So Pons.
Yeah,
That's the story of my name. But that wasn't really the reason why I chose medicine. It was an interesting field anyway at that time. Okay, but my first interest in medicine, or when I had finished, was to become a psychiatrist, really. And I had never heard anything about neurosurgery, essentially. But I went to work for a while with Gösta Rylander, who was a professor of forensic psychiatry. And he had been...
Just let us say, is Rylander who had a role in the study of the lobotomies?
That's
Isn't
right.
That's correct?
Right. He worked together with Oliver Krona in that field. And when I have worked with him for some months, he said, if you really want to become a psychiatrist, you have to see how a brain looks. And my old friend Oliver Krona, he has a position for a few months. You can go there and see how the brain looks at the Department of Neurosurgery at Serafimer Hospital. And well, so I did, and I never came back to psychiatry. It was, well, a fascinating field I entered. And yeah.
So you started with Oliver Krona.
That's
actually.
right, that's right.
Were you the last resident of Oliver Krona?
No, not the last.
No.
But I mean, that was 1953.
53.
And he left 1960.
Yeah.
So, but I trained with him up to 1959. But I started 53, and then, except for 2 years in general surgery in the countryside, I was at the Serafimer Hospital and trained with Oliver Krona. And yeah, so there are a few other residents later than me, but not so many, I guess. But of course, it was a very, very fascinating man to work with, Oliver Krona. He was very demanding, but also very reliable as a chief. I mean, you know what you had to do, and if you did it, everything was okay. And if you didn't, that wasn't very good. But he was working with yeah, firm rules and very very good education for a young internal resident. So, I mean, Oliver Krona, he was from the beginning a general surgeon, and he wrote his thesis about gallbladder problems, and then he went to the States to Cushing and others and started with neurosurgery. And he had operated his first brain tumor 1922, was it, or 23? I've forgotten. And had built up a very strong unit at Serafimer Hospital, which I entered 1953. And there were many people, many residents from foreign countries at that time, especially from Italy and Germany, and South America, and many other places. So it was quite an international, air over this unit.
So it was Oliver Krona, and then he had a number of assistants.
Yes.
They were not called attendants, actually, because he was the only attendant.
Yeah.
But assistants, and they were...
The first one was Olof Sjöqvist, who, well, he's known for the medullary tractotomy for trigeminal neuralgia, which he designed that method. He moved to another hospital, the second department in Sweden of neurosurgery. That was to the South Hospital, Södersjukhuset in Stockholm, in the 40s. But he unfortunately died at the age of 53, 1954. But well, the second assistant, I think, was Gösta Norlén, who later moved to Gothenburg for the unit there. If you should characterize Oliver Krona, he was a very stable and reliable and conscientious surgeon, but he wasn't as brilliant as Gösta Norlén was. But Oliver Krona's real strength, I think, was in diagnostic neurology, and he organized the work and the histories had to be written very carefully in chronological and localizing order, so you can from the history you can see the
So you mean
diagnosis directly.
the young resident has to write the history
Yes,
as a physical.
yes,
And Oliver Kroner, you mean he controlled every
right. Yes,
physical.
yes.
And if it was not,
Good.
Correct.
He threw it away.
throw it away and you had to write it again.
Okay, that's
Yes.
right. That's,
Now it happened second or third time. Would he fire you or?
yes, I think so. It didn't happen to me.
No, but he
Yes.
would fire a young man who would not do good physicals.
Oh yes, at that time that happened, of course. Yes,
Yes.
yes. He was well quite firm in leading the department in that way.
What was like your day? When did you start and when did you
In the morning?
finish?
Well, it wasn't. I mean, we started 8 o'clock, I think, and
Yes.
and worked up to 18, and then we were on call sometimes. And but well, I have no. Yeah, there were full days, and you had every third day or something you were on call.
Now, as a young resident, had you a possibility to see your chief a little closer? I mean, not only the mate of the chief, but to have some glimpse of him as a human being. Was possible or never?
Yeah, there was a distance, I must say, between him and the young people. But I met him when he was not too far from retirement, so he had come down quite a lot.
Mellowed a little.
Yeah, that's what they told me. So, well, he could joke and we could speak also, but still you had an enormous respect.
Now, aside of his skill as a neurosurgeon, had he a cultural background? Did he read? Was he interested in art, in literature, or only neurosurgery and golf?
He didn't. I didn't get in touch with him in other fields than neurosurgery, I must say. So I don't know exactly of his private interests.
I asked you because I had a totally different picture of him when I met him and did work with him. It turned out that he read a lot. And he read everything, good literature, bad literature, but he was a devouring reader. And I had a quite different impression of him of what I heard. And what I heard, I will tell you, probably you, it was before your time. It was a Hungarian writer who had a Lindau tumor and came to be operated in Stockholm. Oliver Kroner operated him, and he wrote a book, A Trip Around My Skull.
Yes.
And there he described Oliver Kroner and Sjöqvist, and he described Oliver Kroner as a professional specialist, but nothing else, and Sjöqvist as a cultured, very read, young assistant. What was that? Did you observe this difference, that Sjöqvist was really more cultivated?
I never met Sjöqvist, you see. He died 54, and I started in the middle of 53. So but as far as I've heard, you're probably right about this difference. I think so.
And how about Norlén and Lexell?
Yeah, Norlén was a brilliant surgeon and a good clinician, of course. And he was also a brilliant piano player. He was almost professional. So his fabulous skill in his hands. He was very fast in his operations. And they told me that some spectators wanted to see him operate an acoustic tumor, and they took a cup of coffee and came half an hour late, and then the tumor was out. Which is
Yes, actually, he used to have the visitors will operate 2 cases, then invites them to tennis, beats them at the tennis, invites them home, play a whole concerto, and the man left Stockholm dazed of these talents.
No, he is kind of fantastic man.
Yeah.
And Lexell, may I first say I worked only for a short time with Gösta Norlén. When I finished my specialty training in Stockholm, I went to Gothenburg for a few months before I went to Lund. But I've met him in other later many times. But Lexell, I met the first time in Lund, I think. He was there when I came to Lund in 1959. But I didn't go to his department. I went to Nils Lundberg's department.
Lundberg, you met Lundberg already in Stockholm?
No, I did not. No.
Lundberg was not an assistant of Oliver Crona?
He was, yes.
Yes.
He was. Lexell was born 1907, and Lundberg 1908. And they were close friends and worked together, went to the World War, to the Finnish frontier together and so forth.
That was in 39?
39, yes. Yeah. But then when I came 53, all of them had moved out. I mean, the department in Lund had started 46 and in Gothenburg 47. And Södersjukhuset in the beginning of the 40s. So I didn't meet Lundberg or Lexell until I came to Lund. Yeah.
And you were in the department of Lundberg.
Yes. As a matter of fact, Lundberg was about to write his thesis in 1959 and had a need for someone who could run the department for him while he took leave of absence for writing it. And so he came to Gothenburg and asked me if I wanted to come, and of course I wanted. I was no fresh specialist, and that was a fantastic chance for me to come and start working.
So you moved as a second man in the department of Lundberg?
Yeah, just for the time being, so to speak.
Yes.
But there were 2 departments, as you know, in Lund. It was kind of a fascinating story because Lundberg and Lexell and Lundberg went to Lund 46 together, and Lexell, who was interested in science. He was a physiologist, and he was his contributions, scientific contributions, are very well known, and I think you have probably spoken a lot of Lexell previously. But they went down to Lund, and Lundberg was a clinician who was interested in running the service, and Lexell was interested in continuing his research work, and he did a lot of interesting things there. He started with the echoencephalography, for instance, in Lund, and his work with his stereotactic system also
was developed there.
Yeah, I think so. And he probably, I think he already has started with radiosurgery as well, not in Lund, but I mean, his work.
In 51, he had the idea of the radiosurgery. He wanted to do something. So he was in Stockholm. He made his discovery of the gamma
fibers,
and went to Lund, where he then made more clinical research or development work. It was the echo.
Yes, yeah.
It was introduction of the echo in medicine. It was
Stereotactic frame and things.
frame, yes.
And he started the functional surgery with stereotactic
Yes.
technique.
But you were mostly with Lundberg.
Yeah, you see, there was only one unit first, but then Leksell moved up to Stockholm for a short while to the special unit for neurotraumatology here in Stockholm, which also was kind of a research unit, yes. I should say. It gave possibility for him to work with research. And then, but then he wanted to, and in the meantime, Lundberg took over the unit in Lund and became the head of that. And then Leksell came back, and then they had to make another department for him. So they were two separate departments equal.
Now, the most known contribution of Lundberg in neurosurgery, it was his intracranial pressure measurement.
You see, I think I must tell you what kind of a revolution it was for me to come to Lundberg. As I told you, Olivecrona has very well-structured unit, and all the methods were very outlined, but no one dared to change anything. So it was kind of stationary in a way. So when I came down, and it was in a way the same in Gothenburg with Norlén. That was the same technique throughout. But then when I come down to Lund and Lundberg, there was an enormous surprise for me to see somebody who started to monitor the intracranial pressure. Neurosurgeons had since the 19th century known about that high intracranial pressure was dangerous, it could kill the patients, and we were running at the Serafimer Hospital. We put burr holes in the neck of the patient in the occipital region, and were running and pushing needles when the patients got
acute intracranial pressure.
Yeah, got high intracranial pressure. But here, someone had come to the very sensible conclusion: why don't we put in a catheter beforehand, before something happens, and just have a stopcock to open? So when something happened, even a nurse could open the stopcock and release the pressure. And then he started to monitor the pressure. And he got quite a new information when he did so. Because previously one had a static view of pressure as like steady like this, and then something happened and it went to another level and another level, and finally it didn't work anymore and the patient died. But when Lundberg made his continuous recordings, he found that there were many very
patterns of
fluctuations here, which were not at all steady, stable levels. It were different kinds of waves. These are called plateau waves, or he called them A waves. The phenomenon was described before by Chany in France. But what Lundberg did, he could show that it was a certain stage in the development of intractable intracranial pressure. When the high intracranial pressure started to be really dangerous, then those waves came, and then you could at any moment have a respiratory standstill, and the patient might die. And that was quite a new way of approaching a problem from which I saw. And that was the same thing with many other things in the clinical setting there. He was flexible, and one more could try different ways of improving things. And that was a very fascinating experience for me to see when he was registrating, and that was made as a routine. That was also a special thing. I mean, it was clinical routine. It was not only for the purpose of writing a book. It was for a routine method, which was his intention. And beforehand, everybody has been so frightened for meningitis if you put in a catheter into the brain or into the spinal system, to the spinal fluid system. But so what he started with was to improve the technique to avoid infections. And he put a little rubber stopper, put a burr hole, and then he had a rubber stopper and around the catheter that was pushed into the ventricles.
And then closed the skin.
And then closed the skin. And if you got an infection in the skin, the infection didn't enter the brain because the rubber stopper was there, which was very simple but ingenious idea, really. And then he went to the industry and asked for stable recorders and stable transducers. They were big, huge things that usually were sitting out in an industrial environment, in which could be rushed around in a hospital without breaking. So that was some very practical views of ways of solving the problem, how to monitor the pressure. And I mean, if you know that the problem with intracranial surgery is high intracranial pressure, it's so obvious when you think of it now that you should measure the pressure to have a control of it, so you know when you have to act. But that wasn't so before.
No.
So, I mean,
today we take it as a
yes, for granted. I mean,
granted, and
now
we forget how it was the
Yeah.
idea and then how it was developed.
Yeah.
But what I would like to raise here, two things. Maybe they are indelicate, but I think for the history would be very important. One of these, that when Lundberg wrote this thesis,
yes.
Lexell reacted to that, and he contended that is not ethical to experiment to open and close the cock. Is correct? What I
Yeah,
said?
well, he had objections against the
That,
ethical side of
yes.
it.
Now, what do you think about that?
Well, I think, first of all, I think it was completely wrong, because what was done, he put in the catheter and had the stopcock and could open it if the patient had headache and were to die. And then there were some patients who were doomed anyway because there were malignant tumors we were unable to solve them for any reason. And some of them he followed to death, but he didn't. Their situation were not
Really
worse.
not experimental.
It
That
was
is
not
what you say.
experimental.
Now, Lexell took up this problem very often and discussed very
Yes.
often with me.
Yes.
And he contended that it was a patient with a glioblastoma. And it was clear that Lundberg closed the cock, waited until the pressure rose, the dangerous level and then open it. And that is what he meant that he's experimenting. That is not correct?
Well, you see, he had a lot of spikes, and so the pressure could rise even normally, and of course it could rise if you closed the stopcock. But for these patients, continuous drainage of the CSF was not a possible way of treating them or curing them.
You mean it has to be closed for a while?
Yeah. When you open it in a short time, all CSF will escape, and then all the catheter will be blocked. So we'll reach about the same effect anyway. And the patients, I mean, we don't always now either open the drainage when we have patients who we know have to die. I mean, we cannot treat all of them, and so.
You mean Lexell overreacted?
Yes, I think it
Yes.
did.
Now, my second question is this. Lundberg's thesis and his activity triggered an enormous activity.
Yes.
I mean, a society was built, symposium after symposium,
Yes.
and even today there are symposiums. They were developed aggregates for intraventricular, intraparenchymal, submachine, etc.
It's a routine method now to
Yes,
measure the pressure.
precisely. Now, again, in the perspective of the time, what do you think? This 30 years development or 20 years development? How long when he started? When was
He started, this is 1960. It's published
1960, so
1960.
more than 30 years development.
Yes.
Did this method yield a lot of important things during the 30 years, or it was a flop? What do you think?
It has. It was the start of the real investigation of the intracranial dynamics. Beforehand, I mean, you have to have continuous long time monitoring to see what intracranial dynamics really means, and you have to find out the effects of CO2 and different drugs and hypoxia and ischemia and everything on CSF, and still this method of ventricular fluid pressure recording is the golden standard, because with all the other methods you are not quite sure of the pressure recording. So most research workers who studied intracranial pressure still do it with intracranial.
So you mean this idea of Lundberg stand its place even after 35 years?
Yes.
34 years.
And I think he is still cited very much. I think I suspect that this is the most cited book of Swedish neurosurgeons.
Yes. Urban, try to refresh your memory and tell us more about Lundberg, and then about his pupils, and what did the pupils, how they developed, which contributions they came, international and, of course, Swedish.
Oh yeah. First, Nils Lundberg. He was a clinician, interested in operating patients and treating them. And another thing which in which he was a pioneer was in the use of the respirator, artificial ventilation. He wrote. He found a straight relation between the PCO2 and the intracranial pressure, which he could could verify, and also advocated the use of artificial respiration for severe brain trauma. And he was very specific in saying that artificial respiration should start early, before the patient stopped breathing, because if he waited until then, the patient was already more or less gone. So that was his great contribution also from him. Other people took this thing up. For instance, Emmerich Gordon here at Karolinska was a neuroanesthesiologist that Oliver Krona got from Hungary in the early 50s. I met him when I came there, and he worked very much upon the problem with artificial hyperventilation as a routine method for treating brain trauma or brain damage of different kinds. He was also early in using the operative microscope. I think he was one of the first of the Swedish neurosurgeons who really used it more routinely.
Actually, Norlén never used it.
That's right, he didn't.
And Boom didn't.
No,
yes.
No, very little at least. So, he did, and now it's a standard procedure for us neurosurgeons to work with a microscope. Okay, but he. When I came to Lund, 59 and 60, there was another young man coming also, who was, he had been working a little in the physiology department, and his name was Bo Siersjö, and he was interested in writing a thesis about acid-base metabolism of the brain, and had been working with David Ingvar and Niels Lassen and German research workers like Lübbers about PCO2 electrodes and things like that. And he wanted a place to work, and Nils Lundberg heard about that, and he gave him place and support in the Department of Neurosurgery.
So actually, Bo Siersjö was taken in neuroscience by Lundberg.
That's right. Yeah, I mean, he has started in neuroscience, but he got his platform to work, and for several years he was working within the neurosurgical department in Lund, and later he got his own department, Brain Research Laboratory. And I started to work with him very soon, and he wrote his thesis, and I was the second one who wrote the thesis in that group. And later on, a series of neurosurgeons have written their theses together with
PhD thesis, yes. How many is there?
They are 21 now. 21 of neurosurgeons, and then there are a lot of anesthesiologists and surgeons and all kinds of different people. But that has been very important for Swedish neurosurgery.
But would you characterize the importance of this Siersjö activity and the Siersjö laboratory? What did they attack? The problem of the ischemia, no?
Yes,
that is.
yeah.
Characterize that little so that the people who look at this video understand the importance of this activity.
Yeah, I mean, there was an enormous activity in the early 60s with intracranial dynamics, which was taken care of by ICP recordings and Lundberg's thesis. But at the same time, it became apparent that the damage that occurred was, in essence, ischemic in most. I mean, it was brain ischemia that killed the patient when the intracranial dynamics didn't work out. You got too high pressure and too low perfusion pressure and an ischemia. And then Siersjö's his line has been from acid base to energy metabolism and then to Beckelis for secondary brain damage. And that is a continuous evaluation of evolution, I should say, of the treatment of or traumatic or cerebrovascular or other intracerebral damage of different kinds, traumatic.
Could you name a number of colleagues and their really important work coming out from this Bussier laboratory?
Yeah, Nick Svetnow has written part of his thesis there, and that was about secondary hyperemia and ischemia after high intracranial pressure.
And I think in this thesis the most important thing was that he established where is lowest pressure, where then still there is autoregulation.
Yeah.
And then when this autoregulation is disrupted. Is correct what?
Yes.
Yeah.
Yeah.
And then who else?
Yeah, there are many of Bengt Ljunggren has worked with ischemia in sudden increase of global ischemia and the effects of global ischemia on the lactate metabolism and on the acid-base metabolism also.
Who were the people from abroad who stayed longer or shorter time in this laboratory?
Yeah,
Brock, Mario Brock was sometimes,
never,
no?
Yeah, no, he never stayed and worked with Siersjö, but
he worked with Lundberg, or
no, not really.
Neither.
No, we had many contacts with him, but no continuous
work. How is about Langfit?
Langfit was also a very good contact for Lundberg and for us and for me and others. His work was to a great extent experimental in Philadelphia, but I must give Langfit the credit for discovering this thesis, Lundberg's thesis.
It was he who discovered?
In a way, because this was written in Acta Psychiatrica and Neurologica Scandinavica, which is a paper with a
restricted
very
circulation,
restricted circulation, and wasn't known really in the States. But Tom Langfit, who had done a lot of experimental work on similar aspects of intracranial dynamics, he got hold of this thesis, and then he said, well, everything is described in man. And he went out and told that in the public, which I think was a very generous way of approaching approaching this. And Langfit and Lundberg were very close friends also.
What do you think, who is today the most representative person for this work of Lundberg?
Representative, what do
Yes,
you mean?
I mean who continued and produced most.
Yeah, it's so many who are working with intracranial pressure. One, I mean, at the same time also the Glasgow group was with Brian Jennett and Douglas Miller and many others were working. And Douglas Miller now is a person who is kind of similar to Nils Lundberg. He has a strong clinical interest and has done a lot of very good research of different kinds. And he is one of the great experts. And then in the States, I mean, Langfit doesn't do any research anymore.
No longer. How is about the group in the UCLA with Becker and the group in Richmond who were involved in that?
Yeah, the group in Richmond, I mean, was a very important one, and that was Becker and Pavlychok and
Young.
and yeah, and many others. And Becker is still, I mean, one of the leading men there, and of course Larry Marshall.
In traumatology, mostly.
Yeah, but even in
measuring the monitoring the pressure
is monitoring. It's I mean, we are coming now over to kind of neurointensive care because when you start monitoring the intracranial pressure, you start then you have to do something about it, and that is neurointensive care.
Yes.
So and then there is many people working now on this.
Now let us make a further step. You did work in Lund long time, and once the chair in Uppsala, you were appointed as professor of neurosurgery in Uppsala.
Yes.
It's very interesting. Lund and Uppsala, they are two old universities, not only for Sweden old, but even for Europe.
Yes.
One, which is the older?
Well, in Uppsala is the oldest one.
Uppsala is older. Lund one was established.
Lund was established as a Swedish university in late 1600 when we conquered the Danes and took over Skåne. I don't 1670 something.
So 1670, and then Uppsala?
Was 1477.
1477. So you came from the old Lund University, has even now a big name in Sweden and in Scandinavia, and you came to the Akademiska, to the University of Uppsala, which was established in 1400 and something.
Yes.
How did you feel? I mean, so many hundreds years behind you.
Lund and Uppsala are very similar. They are small towns dominated by the students and the universities, and they are very charming in a way and have areas which are very beautiful and nice. And it has been very interesting and easy to work in both those places, I should say.
What did you consider as your achievements? Well, in the life of a human being, you cannot do very much. When the people say that I have 300 publications, is the wrong guy, I used to say, because too much. You can do good things, very few good things. So you could say, what do you think? What do you consider as an important contribution of yours to neurosurgery?
Well, I will look upon it as this, that I have been lucky to have been able to follow the evolution of intracranial dynamics by having working very close to Lundberg's work, and also to research about ischemia, hypoxia, etc. by the work together with Siersjö. And I have done smaller parts of that work in both fields. I wouldn't say I made any great breakthroughs, but what I've been interested in is to integrate these things in clinical work, in routine clinical work, to have a well-functioning neuro-intensive care, which is sounds to be an easy way to organize, but it really isn't, because you have to get it has to function around the clock. I mean, around the clock, around the years. Which means very much educational work and trying to establish supervision, concentrate what we should supervise to the minimum, but still the necessary things.
You mentioned education, and that is a very important point. You were many years professor of neurosurgery, so you felt that your important role and duty is to educate the young people. And my question is that, how did you select your people to have the best of them? How did you make it? With interviews? Or how did you decide that, yes, I want this man and I hope that this man will be good to the patient, will perhaps have some contribution for the future of the neurosurgery, etc.?
Well, I may know how I would like to do it, but as a matter of fact, in Sweden you have very little influence of who will be on the staff. When I came to Uppsala, there was many people, and what you have to find out their qualities and work with the people who are there and try to persuade them to go in different directions, which I find reasonable for their skills.
But if you would have a free hand now, today, which would be the criteria? How would you select your collaborators?
I think they must have a research interest. I think that is necessary, and then they also must have a sincere interest in taking care of patients too. I mean, you need both things, and how you select them is, I mean, I think that will be by letting them work for a while and see how they work, and of course interviews in the beginning, but then you must have the possibility to make up your mind definitely,
and even send them away if you feel
right.
that he is not fitting the.
That's right.
Yes.
But I think it's essential that they have a drive of research interest, at least. Of course, I mean, we in a department, people who are only interested in taking care of patients can do a lot of good work as well. But I mean, if you want to get collaborations that you will evolve to something great. You have to have both these things.
Now, when you speak of research, you mean only basic research or also clinical?
Also
research?
clinical research. What I think is necessary now is to come closer to diminish the gap between basic and experimental research and clinical research.
So you mean it's correct what is usual in the States, that a department of neurosurgery has its own research department,
Yes.
and not that you have the clinical departments and the basic research departments. You feel that it's necessary to have a research department attached to your neurosurgical department.
Well, I think the Seattle lab was a very good model, which, I mean, it was a special unit, of course, but the ties were very very close. To. So you need basic research as well, and then you need people who work a little in both places and can bring them together.
Now, what is your experience? Take Uppsala or Lund. How pertinent were this basic research after 5 years, after 10 years, after 20 years? I mean, here we have a case where even after 35 years, that is pertinent.
Yes.
Now, if you take this research work in a basic research laboratory, what do you think the percentage of the production of the work coming out? What is the percentage which after 5 years or 10 years is still pertinent or is just forgotten?
Well, it's so much written now, so there must be a lot of things that that will be forgotten. But it also, well, it forms some kind of a background. I mean, we are moving along the field, and many people are contributing small pieces, and our ideas clarify, and we need verification from different sides and so forth. So I think we have to have some redundancy of research to
have something which will be pertinent.
That's right.
Yes. And how do you think there is a lot of discussion of the sponsoring of this research? Do you feel that the sponsoring should be only by the states or only by special organization, or it should be accepted also from industry, some sponsoring?
I think there must be a basic support from state and government of different kinds. But I think you might very well have support also from industry and commercial, from the commercial side. But you have to be very careful then that the research still is free, is not can be published. First of all, I mean, what I'm against is that if you do something, you are not allowed to publish it. That is a dangerous way of.
Yes, but of course these commercial companies have an interest to have published this research.
Yes, yes.
But let me take an example, because I think it's very important to have it clear for us. I think about the coils. About these coils which are used by the endovascular.
That's right, yeah.
Well, the history of it is Mullen. Sean Mullen did 30 years ago or 20 years ago the first introduction of metal coils in and so on. And then he didn't continue because he was not sponsored, nothing happened. Then, when the endovascular procedures developed, the companies started to think that that could be a very useful thing. And when Guglielmo and Moret came with these coils, actually the industry developed them to something which is fantastic today, with these memory coils, etc. Well, where is the limit? What is where do you have to stop? Because it's clear this is a business. These coils are sold and will be sold. Where is the limit?
Well, I mean, of course you can try those coils in a scientific manner and do an honest job. However, whatever the financials agreements are.
So you mean if the scientist makes it honestly, good and bad, writing and then publishing it, then it doesn't matter what then it happens with the finding.
If it's
How
published
it
or
is
not.
used. No, he should publish it.
Yes, of course.
And to write everything about the drawbacks and the positive things.
Right.
But then, how the industry will use it, how much will earn, that is not the problem of the scientist. That is what you mean.
That's what I mean. Yes.
Yes.
I mean we must be possible to extract from that thing, and maybe we have to discuss it within our profession, how the actual contracts should be written and things like that.
Now, Urban, how do you see the future of the neurosurgery in Sweden, especially, and in the whole world in generally? What do you think? It was a period 30 years ago when we thought that we achieved everything what is possible. And then it came the microscope, it came the radiosurgery, etc., the imaging and so on. So it's a formidable development. Yes. Do you think that it can be another 10, 20 years of development like that, or not?
Yeah, I mean, the imaging can improve more, I think, but not, yeah, and then the use of the imaging, I should say, by 3D simulations and things like that. I think that is the way of using the information.
How about the technique, the neurosurgical technique? Do you think it will it will improve, it will develop, new things will come in?
What I can see is interventional radiology being an important new addition to our to our tools, yes, which might take over most of animal surgery, and maybe together with radiosurgery, and also maybe also arteriovenous malformations.
What about the keyhole surgery, the endoscopy, which now is discussed along? What do you think about that?
Yeah, I think that, but that is a technicality. I think it is elegant and easy. I don't think it's such, in principle, such a difference. I mean, it's a very elegant method, and you can do it. It's economic, an economically better way of doing many things, for instance. But the interventional radiology, I think, is a major contribution which is coming. And then the 3D visualization of both both of structure and of, for instance, metabolism with PET and MR and things like that. We can get and also MEG and all kinds.
You mean the pre-surgical management, the diagnostic.
The diagnostic.
That is important because in this way you will improve also your results.
That's
surgical
yes,
results.
yes, and you will look at functional changes and the localization of things that has to be corrected surgically.
And how do you see the future of the Swedish neurosurgery?
But yeah, what I think, one important thing which we will have to continue, I must say first, is neurointensive care, because that's a necessary basis now for acute neurosurgery, at least. I mean, for trauma and cerebrovascular lesions of all kinds. There we can continue make improvements by.
So again, you are speaking of the peri-surgical
That's right.
management.
Yeah,
yes.
but I think that, I mean, neurosurgery from the beginning evolved from surgery and neurology. I mean, which was combined from different sides. But now we have the third leg now is neurointensive care, which is taking care of the preventing secondary brain damage in different situations.
And you feel that in this field there will be developments and
yes, I
achievements?
think, yeah, it will continue to develop, and it has to do it. And I think talking about research, that it's so much is coming now of different drugs, blockers for different blockers and things like that. So we cannot test all this by randomized studies anymore. We have to rely upon another type of clinical research, and that is to study few patients, but study them very intensively, and have to have endpoints that are much closer. I mean, see what happens with metabolism if you go in with a blocker for something instead of trying to see if with a randomized study which takes several years, and then in the meantime science has come to another drug that has been tested. I think that will be impossible to continue this way of trying out the methods for neurointensive care.
What do you feel, what will be the treatment of the tumors? Shall we take the benign tumor for the meningiomas with this hormonal treatment? Do you think that it will give anything, or?
Yeah, I think it will. So just now I think it's a combination of surgery, hormonal treatment, radiosurgery for instance the meningiomas on the skull base and things like that. Here the surgical technique has improved substantially the last decades, I think, and may continue to improve for a while, but not too much more, I guess. So I think we'll have to hope that we can medically control tumor.
Any experience or thoughts about the treatment of the infiltrative tumors? And second, about the treatment of epilepsy?
Well, the intracerebral tumors, I guess, is a problem where neurosurgery has a limited role. I think we have to, to solve that problem, I think we have hope for tumor biology solutions. Of course, what we do now is palliative surgery, which is important, of course, but not the final solution. Epilepsy surgery is booming right now again, and of course the results seem to be fairly good, and there are some interesting ideas, for instance, with radiosurgery about that, but we'll have to see what that will lead to. So far, it's the conventional surgery, but with better methods to select the patients, I should say.
Mm. And now, to finish it again, what do you feel about the future of Swedish and in general Scandinavian neurosurgery?
Of course, Scandinavian neurosurgery had a very important role in the early days, and it's not possible to reach the same level of influence. But I think we are still have a lot of good research done within the field of neurointensive care, within the field of brain damage mechanisms of different kinds, and that is a combination of experimental and now clinical research with, for instance, microdialysis coming up as a possible clinical method for monitoring chemical changes in the brain.
You mean this Ungerstedt method?
Yeah.
The Ungerstedt method to take.
Yeah, I mean, it's an older method than Ungerstedt. It was invented before, but he has done a lot of work on that, and we have worked with him when we started in Uppsala with microdialysis, when we started to use it in patients. And I think that is not established definitely what we can do with it, but it's a promising way of looking into the functional way of the function of the brain tissue during the intensive care, and that can be complemented by both PET studies, also typical method for functional studies of different kinds, and also with MR spectroscopy.
And you mean you used already this dialysis
we use
routinely, or anyway, you used it in patients?
We use it in patients, and and we can get information which tells about possible ischemic damage coming up, but it's still a lot of work to do before it can be regarded as a routine method, but it's worthwhile testing. But I think we will have possibilities in Sweden to be fairly well in the front within this field in different parts of Sweden. In radiosurgery, of course, we will also have the possibility to keep up, since it was the strong tradition still being here. And I think the general standard of the neurosurgical care in Sweden will stay high. So But well, we will have to have a lot of collaboration within the country, but also with other countries, and which many of the Swedish research workers do have. I mean, with the American laboratories and Anglo-Saxon and German and several others.
So you look forward for another 50 years to monitor this development.
Yes, I don't think I will see it.
Urban, thank you very much on behalf of the Cushing Society that you came and gave this interview.
Okay,
Thank you very much. Thanks.